What's up, guys? I'm Sarah.
And I'm Haley.
And we're
the Device Girls. Our mission for our podcast is to inspire and empower,
educate, and learn all about the medical and healthcare industry as a whole.
So tune in, and we hope you enjoy this episode.
Welcome back to today's episode. We have a very special guest on with us this afternoon, Dr. Ashley Bradshaw.
Hi.
Hi. Thank you so much for joining us today.
Thanks for having me.
Yes, of course. So Dr. Bradshaw is the newest bariatric surgeon to Abilene, and we are so excited to have her here and join with us in this podcast episode.
Yay.
And then, but more importantly, this community. So super excited to deep dive into what all things bariatrics, GLP-1s today. And so let's kind of go ahead and introduce yourself, Dr. Bradshaw.
Like she said, I'm Ashley Bradshaw. I'm a bariatric surgeon and general surgeon in Abilene, Texas. I lived in Wyoming, is where I'm from, trained all over Texas. My last kind of bout for training was in San Antonio. Fantastic group, learned a ton there, and I was able to bring all my skills to Abilene in this community. And I'm really excited to be here and offer kind of a new service line to this area that hasn't really been offered before. You know, health and wellness and people just being healthy. That's what people want. And so I'm very excited to kind of bring that to this area.
Absolutely.
That's awesome.
Well, can you talk to us a little bit about what your schooling looked like and what made you want to pursue becoming a surgeon?
Yeah, absolutely. Yeah. So I chose to do biochemistry for undergrad.
Okay.
So it's a lot of metabolism and kind of learning at the cellular level. And then I ended up taking a couple exercise physiology classes. I'm an ex-Division I athlete, so exercise phys was like, a fun class for me to do. But in that class, I had a project that I had to do sort of, the title of it was a prescription for diabetes.
Okay.
And so my mom helped me. We actually made like this whole pamphlet. I delivered it to multiple primary care offices. And it basically was showing people that if you do exercise, you can potentially reverse if you are pre-diabetic. And so I made my mom pose for all these videos and like things for camera. Yeah. It was very funny, but that just kind of preluded into what I was going to eventually kind of go into, is just helping people cure their diabetes, help to cure some of these chronic conditions, which is that's what bariatric surgery does.
Mm-hmm. Right.
So that was at Colorado State University there. Went to Creighton University for medical school, which I chose that school because my grandfather, which I never met because he had a brain tumor when my mom was about 17. He died there, and he actually donated his body to the med school.
Oh, wow.
Which sounds super weird, but my family had great care there, and they really just loved the kind of Jesuit kind of, mantra that they had there as far as giving back to the community and giving back to just people in general. And so that's why I chose to go there.
That's amazing.
Took me to Michigan for part of my residency, then to Fort Worth to finish my residency, and in San Antonio for a fellowship. So it was a lot of fun. I've learned a lot of things along the way, good things, bad things, things I want to do, don't ever want to do, be like, don't ever want to be like.
Yeah. That's awesome. What brought you to Abilene?
So I knew I wanted to stay in Texas when I, looked for, a job, and I just wanted to be very aligned with, how I really wanted to start a practice as far as kind of like a holistic approach, very all, encompassing person, not just addressing do you want the shot? Do you just want surgery? Kind of treating the whole person and kind of envisioning and aligning with their goals for life. Like, do you want to get better and healthy for your kids so you can run and do that? Do you want to run a marathon? Do you want to, whatever you wanted to do? So this environment seemed to support that, and that's why I ultimately chose to come here.
That's amazing. It's also awesome. A great place to raise kids.
Yep, I have a little 7-month-old, so a little girl. So trying to also show her to be a strong, independent female, and so surrounding yourselves with strong, independent females is also, I think, really important. So
absolutely.
That's awesome. I'm a bodybuilder, so I'm super into health and diet and fitness and everything. So I love that you really focus on that. It's amazing.
Anyone hears me talk, I geek out on supplements or creatine or just working out in general.
Yeah.
So I love kind of encompassing that as part of the whole body and wellness aspect. I'm always on people. I'm like, how much are you lifting? What's your protein intake? Mm-hmm. Which that just carries over from being an athlete.
Yeah.
So
what are some of your recommendations for people who aren't as familiar with the fitness world and the gym? Kind of what are some different programs that you pitch to?
Honestly, I think anything that's easy for people.
Okay.
So even if it's just at home, if it's just, taking heavy water bottles and using that for your arm weight, there's tons of great apps out there now. And I usually share, examples of things for patients. You don't have to make this such a daunting hurdle to get over, because going to the gym for most people is a scary place.
Mm-hmm. Yeah.
They're so afraid that they're going to be judged. Everyone's going to be watching them, which is totally untrue. Most people are so focused on themselves and not other people. unless you're doing something really weird. But I just try to help them get over that initial hurdle. Just, maybe getting a couple like little tiny weights or ankle weights or a weighted vest from, a store, and just kind of increasing that with their walks.
Yes.
Just to sort of kind of get that momentum going.
Yeah.
But that's also why it's important to not just monitor people's weight loss. Like, great, you lost 10 pounds. I care more about how much fat did you lose and how much muscle did you gain.
Right.
If you didn't drop a pound, but you lose a bunch of, fat and then gain some muscle, that's what I want to see.
And how do you measure that?
So we have a very special scale at my office, and it actually breaks it all down. It tabulates your water weight, your muscle mass. It does it each arm, torso, leg. It's pretty cool. Very scientific.
Is it like the in-body scan?
Kind of. It's almost
Similar?
like a DEXA scanner, but
Okay.
without the radiation.
Okay.
Amazing.
That's
Most people are
Awesome.
shorter than they think because it measures it with ultrasonic stuff. So people are like, I thought it was 5'6". You're like, no, actually 5.5.
Oh my gosh, we gotta get my husband in this thing because he's always like, I'm 5'11". I'm like, you are not 5'11".
Oh.
We are almost.
Same with mine. He's got on it, and he's like, I'm not that tall. So now I'm like way underscore. I'm like, you're 5'8". He's like, I'm 5'10". I was like, the machine says differently.
Oh my gosh.
Science says no.
That's awesome.
I want to know what it says my height is now. I
Yeah.
teeter between 5'4" and 5'5", so
Uh-huh.
I'd be interested.
Yeah,
to
mine's
see.
definitely down by about a quarter of an inch.
Okay.
So,
Really? Okay.
That's
Interesting.
awesome.
That's funny.
That's interesting to hear you say, because I have a lot of people always ask me like, how much do you weigh with my bodybuilding and stuff? And I love that I can relate to you on this.
Yeah.
But it's like, I always tell people, I'm like, to be honest, like when I'm in prep, sure, I'm weighing myself for like check-ins and everything. But otherwise, I go purely off physique, what my muscles looking like versus am I looking like I have more fat on me? And I weigh a lot more than people think I do, but it's
correct. Muscle weighs a lot more than fat does.
Yes. And so I always like try and harp that to people that like it's so important to sometimes not pay attention to the scale.
Correct.
In my opinion.
And we also encourage people to come into our office that are, say, in athletics or whatever, to get on that scale to kind of see where you're at, because it's a good measure of that, because the scale is just a number. It doesn't really give you that percentile. So that's what I do for myself, is I jump on it to make sure that while I'm working out and stuff like that, that I'm more concentrated on muscle gains. If I lose muscle, I'm far more upset than anything else.
Yes.
So
I get that for sure.
Yeah. Well, okay, let's talk a little bit and deep dive into bariatric surgery. So I love that you brought some props. Thank you so much. Can you walk us through each procedure type and how that's different based on every patient?
Yeah. And so for every person is very different. Their goals are very different. And so that's kind of how we tailor which surgery is best for people. It's based off of, your medical comorbidities, what your goals are, what kind of fits with your lifestyle. Age also plays a role into that as well. So I did bring a couple props, but I think the best thing to start with is I'm going to grab, I think this is the normal one. No. So the very first one, excuse me, Sarah. So this is the sleeve gastrectomy. Probably 80 to 85% of people now have the sleeve. And it's the newest kind of kid on the block. It's the least, what people like to say invasive. I tell everybody surgery is invasive. You're getting cut all the time. You're getting, not all the time, you're getting, the same exact incision. So everything is invasive. As far as like inside rearrangement, correct. It's not rearranging you from the inside as much as, say, the other two surgeries are.
Okay.
So this one is purely restrictive. So when I say that is you only feel the restriction. So the reason, of course, why is when you're looking at this picture, here's your esophagus. That's kind of where the food starts, goes down from your mouth, and then enters this part of your stomach. I end up cutting off about 85% of your stomach with this fancy stapler.
Wow.
So that gets removed from your body permanently. So people are that makes them nervous, like, oh my gosh, permanent. Well, surgery is permanent regardless.
Right.
But a cool hormone kind of lives over here. His name's ghrelin. He's what tells you that you're hungry. So when you have head hunger, that's when it kind of tells you that you're hungry. Okay. And so that gets removed permanently from your body.
Wow. I didn't know that.
Everybody is affected differently. Some people have to set an alarm to remember to eat and drink. Other people are like, hey, you told me that this was going to change and it didn't. It's probably because it's more kind of psychological hunger and not necessarily body hunger.
Yeah.
So everyone's, again, very different. Every patient reacts very differently to this.
Okay.
Most people lose about 60% of their excess body weight with the sleeve gastrectomy. The biggest side effect of this guy, you're like, oh, sign me up. I just have some restriction. I'm not rearranged. You can get heartburn. Okay. 25% of people can develop heartburn. most people take, an antacid, don't ever think about it again. Small group of people, doesn't matter how great the surgery is, who the surgeon was, where it was done, how old it is. That sometimes that antacid is just not going to work anymore. And if that happens, then we had to have a whole other conversation about maybe converting to a different procedure, and not for weight loss, but for the heartburn, or kind of doing something else to kind of augment this up here to kind of recreate a sphincter up there.
So what causes that?
So it's almost just it's called law of Laplace. It's just kind of like a pressure system. By making this a thinner tube, it's more of a high pressure system.
Okay.
We don't get rid of this muscle down here called your pylorus. That's kind of a muscle that helps to release, like when your stomach has food in it, it waits a little certain time to kind of help digest some of the proteins, add some of its enzymes to it before it releases it to the rest of your body. That muscle's still there. And so because of the high pressure system there, it kind of ends, if it's not going down, I tell people it goes back up.
Yeah.
So if this is kind of more lax up here, it tends to kind of go the path of least resistance.
Wow.
So.
And do you, as a surgeon, you allow your patients the option to choose their procedure?
I do.
Okay.
I mean, I will say I am very openly biased to certain procedures, and everything has to be the right fit for people.
Okay.
Right.
So since this is the least deranging, you don't have to worry so much about like nutritional deficiencies and stuff like that. This is much more of a user-friendly kind of bariatric surgery. Some of the other ones are a little more on the, I don't want to say high maintenance, but they require a little bit more maintenance, a little more of a check-in. With this, you have your surgery, you see me the required amounts after surgery, and then at that year mark, we're high-fiving about your weight loss, and then you really only need to see me once every year.
Okay.
With any of these surgeries, I tell people that we are life partners because I want to see them for life. That's how people have the most success, is that follow-up.
Yeah.
Right.
And I've asked patients who've done really well, ones who've done very poorly. It seems that kind of accountability of showing up, even if it's once a year, that really makes a huge difference for people. So this is usually, we also call it a good starter operation.
Okay.
Because technically this can be converted into the other two.
Okay.
So that's kind of what I tell people. So this is the least kind of deranging, easiest one technically to perform. Okay. Usually a good fit for most people. But again, it's only restriction. So you only feel the restriction as far as kind of getting that metabolic surgery effect. You're not going to feel it.
And what does the pre-op and post-op directions look like for a patient?
So for any bariatric surgery, people have to go through kind of like a rigorous kind of checklist. And most of the time it's for insurance purposes, but also we're permanently rearranging you. Right. So we kind of want to make sure that you are very aware of like kind of the lifestyle you have to be on board for.
Right.
So most people have to have a certain number of dietitian visits, at least 3. That's dictated by people's insurance. So you have to kind of check with your insurance to see how many it is. It can be upwards of 10 to 15, depending on your insurance. So you have to really kind of understand what you're kind of getting on board for. Yeah. Also, just kind of understanding how your diet's going to change. So you do have to break up with kind of carbonation. None of these surgeries do well with carbonation. So any of your fizzy waters or sodas, you're going to have to say bye-bye to. High protein, low carb diet. Okay. Like any of these surgeries, you can eat through, 15% of people regain their weight after surgery. Yep. Most of those people, it's because of their diet choices. Whether they're doing it consciously, and most people it's subconscious, where stuff just kind of goes through easier. Like if we were out to lunch together, we both have sleeves, you choose, have a salad with a grilled chicken and some raw fruits and vegetables, you're going to eat like a quarter of your chicken breast, parts of your salad, and be full. If I am eating a, peanut butter and jelly sandwich on white bread with some Cheetos, I'm going to kill that. Yeah, I'm going to not feel any of that at all. And so you have to just make the right choices. And so when people really buy into that lifestyle, and that basically it's kind of like a diet and lifestyle change for life, they do really well.
Wow, so that's awesome.
Yeah.
So I will put this one down here for now because I'm going to save the best for last.
Okay.
So this is kind of the OG, the original one, the gastric bypass. So most people have probably heard of the gastric bypass in some way, shape, or form. So, but like, what is it? What do we actually do? So this one is restrictive and malabsorptive. Okay. So it's a double hit for people. So again, esophagus is your food tube. I don't take anything out of the body permanently with this one. So some people will think that this one is more reversible. Not really. If I physically put these two pieces back together? Absolutely. Does this ever work the same again? No, it doesn't. You'll never have like your normal stomach and how it works again.
Yeah.
So the restrictive portion is I make this little pouch here about the size of a large egg. So, that's not much, right?
That's small.
So if you overeat or anything like that, going back up.
Oh.
So people don't necessarily have the reflux, because this operation treats heartburn and reflux.
Uh-huh.
They end up having more kind of regurgitation, and it's usually
Okay.
kind of like a negative feedback
Yeah.
from eating too much too fast. So
Mhm.
again, you have to retrain how you eat and drink. So the malabsorptive part, this is where it comes in. So I end up rearranging the intestine. So this little pouch that I made, I take another little piece of intestine and I connect him up here. And then since this has been the bypass portion, this is where all of your digestive enzymes come in, digesting food. There's no food in this portion. So all of your digestive enzymes from your liver, from your pancreas, they're all on this side, but they're not digesting any food because there's no food on that side.
Yeah. Okay.
Food goes down here into your pouch where this red arrow is. Food's here, but nothing's really happening. You have no digestive juices. So your food's just kind of going in there, going through this portion here, and they don't join up until about 100 centimeters downstream from each other. Then once they join up with this black arrow, that's when you start getting food absorbed. That's the malabsorptive, the bypass portion of this operation.
Mm-hmm.
So people do have a little bit more weight loss than, say, the sleeve gastrectomy. Also, you have better resolution of your diabetes with the gastric bypass and the sleeve gastrectomy. When I say that, it's like, it seems like for the sleeve, it's always 80-85. 80-85% diabetes curable with sleeve gastrectomy, mostly because of the weight loss. With the gastric bypass, it's getting a lot better. It's getting in the 90s and over 90s for resolution of diabetes. Depends on how long you've been a diabetic. Obviously, if you're a type 1 diabetic, there's no cure for that. Because that's, an actual disease process that's, genetic. So that's why it's malabsorptive. There is, you're like, oh, great, this signed me up. This sounds better. There is some baggage that comes along with it. I say baggage versus complications.
Okay.
So some people have heard of dumping syndrome.
Mm-hmm.
That sounds as awesome as it is. So because this portion of intestine has never seen like complex carbohydrates, so like a baked potato, a chip, piece of bread, never seen like it in that form.
Right.
It's already been broken down quite a bit before it reaches that side. So when you eat something like that, this part of your intestine kind of freaks out. And when it does that, you kind of get like these sweats, racing heart, abdominal cramps, and then rushing off to the bathroom. That affects everyone very differently. Mm-hmm. So there's a huge spectrum of that. Some people can even just like smell sugar and they're like done. They're out.
Really?
Yes. Some people, they can like eat half a baked potato and be like, I never noticed anything. So everyone is very different. It usually gets better throughout time when that intestine gets used to it. But some people, they can never, have like a taste of ice cream or a piece of bread or a baked potato or anything like that ever again. Some people desire that as far as like, I want that negative feedback. I don't ever want to eat a carb, and the best way is to get punished by your body. So some people really want that, but I warn people about that as well.
Yeah.
Other thing, you can never take Advil, aspirin, Aleve, or anything like that ever again. So yes, really easy to make the decision when you're 30 or 40 and your knees, ankles, hips, and don't hurt, right?
You're fine.
Yeah, you're fine. So, but, things change when you're 70, 80, and, having arthritis. It'd really be nice to take an Advil. Yeah. But that's not necessarily, you can't do that with this. The reason why is you can get ulcers.
Okay.
And where you get the ulcers at is right at that connection point. It's for some reason super sensitive. It has to do with the high acid portion of that stomach as well as that intestine. Putting something in there that already kind of breaks on that barrier is just too much.
Okay.
And you can get ulcers there, which can cause bleeding, pretty severe pain. And worst case scenario is it perforates or makes a hole in that area. And then you're signing yourself up for some emergency surgery, which nobody wants that.
Yeah.
So that's one of the kind of baggage parts you have to be careful with the bypass. Other bad part about it is because I'm rearranging intestines, these fat planes over here kind of open up. I sew them, all together at the end of surgery. But let's face it, you lose fat from everywhere, inside, outside, all over. So you're losing fat on the inside of your body as well. And so sometimes those little planes can open up and create little holes. If a hole is in there, then your intestine can get through that hole sometimes. About a 4% lifetime risk of your entire life of that happening. So it's not a huge risk, but something we need to talk about, right? If that happens, your intestine gets stuck in there, it's called an internal hernia. That is a complication. Can happen anytime during a bypass, 50 years from a bypass, 10 years, 2 months, doesn't really matter. But that's an emergency surgery situation. And that's a huge, huge spectrum of how bad it is. If it's been stuck in there a very long time and the bowel essentially dies, most people end up having to have that section of their bowel taken out, maybe put back together. A lot of times they're pretty sick and up in ICU. That's a very rare circumstance. Most of these people are pretty good at knowing their bodies and kind of present much sooner. Because I always say, if you vomit at all ever with a bypass, I need to know and like come in immediately.
Yeah.
Because vomiting is never normal with a bypass.
Okay.
And we catch it sooner, then we can kind of just stay with the little incisions laparoscopically, pull the bowel out of there, let them kind of breathe again, sew up that hole and be done with it.
Yeah.
So
interesting.
Yeah.
So yeah, this one has a lot more kind of finickiness to it because it's malabsorptive. There is no question about you needing to be on vitamins, and they have to be a bariatric specific vitamin because they're at a higher concentration.
Okay.
So your regular, women's daily vitamin or something you get off of Amazon, it's not going to work out for you.
Okay.
It's just not at a high enough concentration. And with this, we have your visit, we're high-fiving, you've lost, 65 to 75% of your excess body weight. You're super excited that I need to see you every 6 months just to check your vitamin levels, just to make sure you're doing well. Because some of them can get pretty low. And if they do, it's pretty critical to get those replaced right away.
Okay.
So,
and what do those vitamins and supplements look like for those patients?
So you're like, oh my God, he's telling me I take you're malabsorptive, I'm gonna take all these vitamins. I'm gonna be like grandma with a handful of pills. No.
Okay.
It's one a day.
Oh, okay.
So, and then taking a calcium, which any woman should be taking calcium, right? We want to prevent, osteoporosis, osteopenia, things like that, because we're all at risk for it, right? So people just take a calcium chew, which are delicious, and then just an oral, vitamin, whether it's a capsule or a chewable.
Okay.
But I say they have to be bariatric specific, and just we need to find the right one that works for you. So
absolutely.
Okay. So do they make just like a bariatric specific multivitamin?
They do multiple brands, and we usually have people try different types of brands to see which fits for them, just because some people have harder times with vitamins than others. And when your anatomy changes, what worked for you preoperatively, high chance it's not going to work postoperatively.
Right.
And one thing to talk about,
that?
because it's smaller, you're rearranged, and then just your taste change.
Yeah.
One thing being in Texas, we all love our red meat. For a bypass, and we do not know why this is, they somehow start to dislike any red meat. They stop eating any steak, any hamburger, period. It's not because they can't tolerate it.
Yeah.
They just, almost the iron in steak, I don't know. We have no idea.
Wow.
But people will automatically just start like turning their nose up at steak, that you were just total like, give me that ribeye.
Yeah.
Like, they're like, nope, no thank you.
Wow.
I'll take fish, please.
Yes.
It's bizarre.
Wow.
Yeah.
Well, remind me to never have to have a bypass.
Absolutely.
I love red meat.
So it's a great operation for the right patient. So,
Absolutely.
and if you do get that really bad heartburn from the sleeve, we usually end up talking about converting you to this guy here.
Okay.
Is it for weight loss at that point? No, it's not. It's basically to fix the reflux.
Okay.
So again, if you are the patient that comes in and you already have really horrible heartburn, I'm probably not going to recommend a sleeve for you just because you're not going to probably do super well. And this would be a better kind of 2-hit for that.
Okay.
So, all right. And then
the best for last.
The best for last. So I absolutely, and this is probably because a lot of my mentors, this is called the duodenal switch. And this picture is of the traditional duodenal switch, which I don't do. I do a modified version where there isn't 2 connection points. There's only 1. So the one is up here and this one is not here.
Okay.
Reason for that is you get the same exact bang for the buck as far as weight loss. So we talked about the sleeve is, 60 to 65, the bypass, particularly 65 to 75% of excess body weight loss. This bad boy is 90 to 95% of your excess body weight.
Wow.
Loss. And it is the most durable. The reason for that is because you are the most malabsorptive. We've made your garden hose much shorter as far as your absorption of nutrients.
Okay.
So that sometimes makes people really nervous. Like, oh my gosh, that makes me a little more nervous. It's okay. It's essentially just a different type of multivitamin. And then we just tell you to increase your protein a little bit.
Okay.
Not a big deal. But the reason why this guy is my favorite, not only because of the weight loss, people do amazing with it is with the weight loss, you also don't run the risk of having that, you can't take Advil, aspirin, and leave. It's a sleeve. This is the first half. It's a sleeve. You can take all of that stuff still.
Right.
Okay.
So are you going to maybe have, knee pain when you're 60? Probably. Guess what? You can still take, an Advil and be totally fine. Resolution of diabetes, almost 100%.
Oh my gosh.
This is my favorite is when we perform these on patients, literally post-op day 1, we're taking people off most, if not all, of their diabetic medications.
Wow.
It's amazing.
Second visit, usually off of all high blood pressure medications. So off of literally all of these chronic medications patients have been on for years.
Yeah.
First visit.
Wow.
Maybe even in the hospital post-op day 1.
Okay.
What other surgeries are doing that?
Yeah.
The shots aren't doing that.
No.
They can help with a whole, other range of patients. But as far as if you have multiple comorbidities, you're pretty heavy. But this is such a great operation.
So I guess my question is, what makes a patient essentially like, what process do they have to go through to be able to, I guess, qualify like for that? Because I don't know why some people wouldn't choose to just do that.
Correct. And so a lot of it is insurance based, which is very unfortunate.
That's what I figured.
Like, so most insurance companies, to get approved for a duodenal switch, modified duodenal switch, or SADI, there's a lot of names for this thing, is usually a body mass index of 50. And so body mass index, that's calculating basically your height and your weight combined.
Right.
And just kind of calculate what that is. Obviously, we already talked about if you're an athlete or something like that, it's usually pretty skewed because your muscle's heavier. So, it might say like your BMI is, on the overweight or obese side, even though you're not. Like there's pictures like, bodybuilders that have like 1 ounce of, fat, but they say that they're overweight because they have so much muscle.
Yeah.
But that's what they calculate all these off of, most insurance companies. So 35 is usually kind of their threshold, depending on the insurance company. Some are very progressive and follow the ASMBS's guidelines, which basically say BMI 30 makes you a candidate for any sort of bariatric surgery.
Okay.
But just whether insurance companies kind of get, wanting to pay for these things is a whole other topic. Yeah. So above the pay grade of this podcast.
Yes. Okay.
But and then people, they do their dietitian visits. Everyone has to have a psych visit. We don't think you're crazy. Again, we're rearranging you completely. So we want to make sure that you understand, like, again, this is a whole lifestyle that you're going to have to commit to.
Gotcha.
And then we usually like to have people start on their vitamins with us. I usually make sure they have I see them at the consultation, we kind of know what's going on. I get some preoperative studies, make sure you don't, if you have a gallbladder, do you have stones in there or not? Dictates whether I want to remove it or not. Make sure you don't have any blood clots in your legs, because anyone who's overweight is higher risk from having blood clots in their legs and getting blood clot somewhere going in their lungs, which would be horrible. And that's really about it. Maybe we'll do kind of an upper endoscopy. We're taking a little camera, go down people's mouth, esophagus, look in their tummies, make sure they don't have any signs of horrible reflux or acid in their stomachs. And that's about it. Usually takes anywhere between 2 and 6 months to get worked up. This very much depends on usually the number of nutrition visits, honestly.
Okay.
So once people are ready, then we kind of set a date and go from there.
And for those nutrition visits, what do those look like for those patients? Is there an expectancy of, I need you to stick to this diet?
I mean, a lot of it's just sort of like their first visit is kind of getting to know them. Like, what are your eating habits? What is your, essentially kryptonite? Like what kind of gets you, like, if you got to keep it out of the house type of thing.
Yeah.
What are your eating habits like? Most people aren't really aware how much they are overeating, even if it's healthy food. It's like, what are actual portions? And most people are pretty blown away. We usually recommend people to either get like really small containers, because we're so trained to eat everything off our plate, right?
Right. I mean, because anytime you go to a restaurant, it's huge portions.
Yeah. It's kind of rude, essentially, to actually leave food on your plate.
Yeah.
Correct. We're trained. That's our culture, right?
Yeah.
And so we kind of just try to say, all right, try to eat off of children's plates or the salad plate, to have kind of try to control that portion size versus, big Thanksgiving plate where you fill the whole thing, right? We're all uncomfortable and sick after Thanksgiving. Yeah. That's not normal. And so some people eat like that every single day because we're just trained that way. So that's kind of their first visit, just kind of like, what are you doing? Giving some advice as far as like, okay, learn to love protein drinks. That's a huge thing for bariatric surgery, because that's a great way to get that protein in without, eating it all day long, because they can't eat a lot in one setting.
Right.
And just kind of having them try. Is there like you have to lose weight, requirement? Like you must lose 30 pounds in a month. No, not at all. Okay. I just want to see that people are maintaining that weight and not going up. Because if they're going up, then we need to have another discussion or, meet with the nutritionist, or we're just not quite catching that, like, we can't just continue to drink Mountain Dew every day. We have to drink water.
Yeah.
Right.
So, but do you feel like a lot of your patients, when they come to you, they're ready and they're committed for this process?
People have thought about weight loss surgery for years before making that extremely brave step to come see somebody and ask for help.
Yeah.
So all those people have thought about it for years, have thought about making the point, maybe picked up the phone and then hung up, because it's, it's scary. Most people, unfortunately feel some shame and embarrassment, and no one should ever feel that way.
Yeah.
You're looking for help to run with at the playground with your kids. You want to go to theme park with your family. You want to fit in an airplane comfortably without having to ask for a seatbelt extender.
Mhm.
These are basic things that honestly we all probably haven't had to think about.
Right.
You know, but this is like a daily affecting life
Yeah.
situation for a lot of people in this country, especially in
No.
Texas.
Yeah.
It is. Yeah.
Everything's
There's a guy I know. I had no idea that he used to weigh so much because like he just looks like a normal, you know, skinny guy now.
Mhm.
And so one day he like started talking to me about it and I was like, what?
Yeah.
So I can't remember which procedure he had done, but anyway, he was like one of those really good patients. He stuck to it and now he looks incredible. And I was just like, wow.
That's amazing.
Yeah.
What's your favorite thing about when a patient comes back and just
Yeah.
like you can see how much you're impacting their life?
Every visit is so exciting because you see like, you know, things that are changing or asking them like, what are you able to do now that you weren't able to do a few months ago?
Mhm.
Yeah.
And hearing, like, we always talk about like non-scaled victories, right?
Uh-huh.
You know, what is it? We have like a
Yeah.
board in our office where people can write down like that they had a healthier pregnancy. They're off all their medication.
Mm.
They were able to go to Six Flags with their family. You know, being able to
Mm.
celebrate that. That's why this job is awesome. I get to celebrate awesome crap with people,
Yeah.
you know, like versus, you know, telling, you know, being at the worst time for people. I like to be at the best times for people.
Absolutely.
Right.
And so,
Yeah.
and that's what makes my job fun.
Yeah.
So.
That's amazing.
It's incredible. It's like bringing tears to my eyes.
Yeah.
Oh, patients make me cry all the time. Like I'll be like, stop it. Like you're making me cry.
Yeah. Is it worse post having a baby?
I don't
Mine's
know.
skyrocketed.
Probably.
My emotions are just
Probably. I mean, it's not like, it's like certain people I'm
Yeah.
such an empath. So like I can really like feel when people are struggling. And so I like
Mhm.
feel that with them, you know, that they make, like, you know, breaks my heart or I get really excited for them or it brings like goosebumps to me talking about all the really awesome stuff that they're going to do. So
Mhm.
Yeah.
That's amazing.
So as far as nutrition goes post-op, do you have a specific nutritionist that you work with
We
or
do.
have them work with, and how long do they have to go? How long do you recommend they go? That type of thing.
That's a great question. So we do have a couple of nutritionists in our office. And so it's really important, I think, that you find the right person for the job. So they can talk to those people and we are saying the same kind of mantra, you know, so that we're saying the same exact things. You know, it's not like them just recommending, you know, not as much protein as I am or the carbohydrate thing or the, you know, like carbonated beverages. So we kind of are all saying the same exact thing.
Yeah.
Okay.
The pre-op visits are obviously important so they kind of know what they're getting involved for, but maintenance I think is huge. And so they are required to have a certain number of visits after surgery.
Okay.
And then I think it's also great, like, especially if they, you know, life happens, stress happens. So if they get into that situation where, oh my gosh, I've gained 5 or 10 pounds, it's been a couple of years. Hey, come in for a nutrition visit. Let's just, you know, kick the tires, look under the hood, talk about what's going on. And usually they're able to identify, oh yeah, like I'm not getting as much protein as I should.
So what type of proactive nature does your team in your office work to like reach out to patients to, if you haven't heard from a patient or seen a patient in a while?
So office is amazing. We have a nurse, kind of bariatric nurse navigator who is absolutely incredible.
Amazing.
And so she is like on the phone with these people like on a daily to weekly basis, whether they're pre-surgery, post-surgery, whatever. So everyone feels like there's a lot of touches like from multiple people in the office, just making sure that they're doing okay.
Yeah.
Whether it's from myself, I call most patients, you know, a week or a couple of days after surgery, make sure they're doing okay. She's calling them. Like the office is people. I think people feel very well cared for because that's the truth. Like we really want to see them on this journey and being really well cared for. And that's kind of like why everyone kind of works super well in the office together is because we all have like the same mission. It's just to help these people.
Absolutely. That's a very personal touch. I mean, to me, to think like the surgeon that operated on me, my surgeon's calling me to check on me. Like that's how much he cares.
Yeah.
That's really amazing.
I mean, I think it helps, you know, if pain's not controlled or they're nauseous or something like that, like just to mitigate that, to kind of help them through that, you know, short time, whether it's taking out a gallbladder or an appendix or whatever. It's not just for the bariatric surgery patients. It's everybody.
Yeah.
Maybe you had a lump on your back. I don't care. If you're nauseous, let's do it.
Yeah. Okay, so talk a little bit about some of what you do in general surgery.
So I do anything in general surgery.
Okay.
So lumps, bumps, taking them off. I tend to like to do things in the operating room. I like to have limited patients, kind of participation in surgery, as you will. So I like them out for that.
Mm-hmm.
Plus, I think it's more comfortable for people. I don't like, knowing it's happening to me. So I prefer, I think patients think it's more comfortable, less anxiety and fear. Gallbladders, appendix is more of an emergency situation coming into the ER. Hernias, whether that's you can get a hernia through your diaphragm. It's called a hiatal hernia. That can cause people to have problems swallowing, also really bad heartburn and acid reflux, or just kind of abdominal wall hernias. Inguinal hernias kind of in your groin, hernias from a previous incision, things like that.
Okay.
So kind of like your basic stuff. I would love to do breast surgery here as well, but I haven't had the opportunity to do that yet.
Yeah.
Awesome. So talk a little bit more about what type of procedures you would do to repair a hernia.
Depends on the type.
Okay, so let's touch on hiatal.
So a lot of times everything is done minimally invasive. So that leaves people with the least amount of downtime. So tiny little incisions. I usually tell people the largest ones are about the size of my thumb. I have a little tiny hand, so it's not very big incisions.
Mm-hmm. Yeah.
And just kind of, I use minimally invasive techniques so people have the least downtime.
Yeah.
So, I always say I'm like an old man, and I use, certain sutures, which is like very old man like what they call silk sutures.
Mm-hmm.
But I just feel like people have the best results from that. I also do something called a Lynx, which is just a little magnetic device. You can put it at kind of the bottom of your esophagus in your stomach.
Okay.
That kind of helps to recreate that sphincter.
Okay.
But testing is involved with that to make sure, number one, your esophagus is strong enough to kind of open those little magnets up. So it's called esophageal manometry, and it just measures how well your esophagus contracts. Most people with horrible heartburn will do anything to stop that heartburn because it's all the time, every day.
Yeah.
So
when I was pregnant with Sloan, I had heartburn. I had a horrible reflux, GERD. I mean, I've never experienced that in my life. I would aspirate on my own, essentially vomit during my sleep and wake up not breathing, like just gas. It was horrible.
And that's people's every day.
I could not.
Wow. So most of those hiatal hernias, I don't usually use mesh, but again, that kind of dictates on how big the hernia is, what the patient's like. I usually don't use mesh in those.
Okay. In what cases would you use mesh?
If I cannot bring their diaphragm together, there's like two muscles on either side of your esophagus called your Kruse. We kind of suture those together just enough to allow the esophagus to go through without having a huge gap. That's what makes that hiatal hernia, is that big gap, that kind of hole between those two muscles. If I can't get it together very well, or I can't use that magnet sphincter device, or I can't wrap a stomach around, to kind of help bolster that a little bit, then I might try to put a little bit of mesh in there just to kind of like, in my mind, think that it creates more of like a scar tissue reaction to kind of prevent any recurrence. Whether that actually does anything, the data is not quite there, but I think it's just more of like a helps me sleep better at night maneuver than anything.
Mm-hmm. Yeah.
So, what's your favorite procedure, not a general procedure to do?
I still will say this day in and day out is a appendectomy.
Really?
Oh my God, yes. Because people come in horrible pain. It just came on. Oh my God, this is horrible. I hate this. I'm in so much pain. You take that little sucker out, instantly better. It is
amazing.
So satisfying.
Yeah. It's a super quick procedure too, right?
It can be very quick. It can be anywhere from 5 minutes long to 20 minutes long. So
wow.
It's always nice when it's a nice little juicy sucker just laying right there. You can just lift him up, chop, chop, and he's in a bag and done. That patient is cured of that problem, and they feel much better like instantly. It's so rewarding.
And do they get to go home? They go home quickly.
Yep, right away. Right after surgery, they go home.
That's awesome. Touch a little bit on what exactly the appendix does function wise and like I learned it in college, but I can't remember. And then do patients have any like effects after without having their
that's a great question.
appendix?
So your appendix, say my arm fist is like your colon. So variform appendix, variform in Latin means worm. Mm-hmm. And so he's like this little worm guy that lives off of your colon. So they think back in the day when we used to eat bark a lot more that it helped to digest cellulose in bark.
Okay.
Other people have suggested that the bacteria that kind of lives in the lumen of that appendix, if you were to lose all of the good bacteria in your colon, that your appendix can repopulate that.
Oh.
We can also do like fecal transplantation now and other things. And we're much better stewards of antibiotics to not wipe people's colons out completely of their antibiotics.
Mm-hmm.
So most people really don't need that little appendix. And so that's what we say, because some people call it a vestigial organ where we don't really use it anymore.
Right.
I still think he probably has some purposes to him, but can you live a normal, happy life without it? Yeah. We take them out of children all the time, especially during changes of seasons. All that lymphatic tissue that children have clogs that little lumen up of that appendicitis. And a lot of appendixes come out usually in the spring and fall.
Is that a more common procedure to see done in children versus adults?
It's more commonly benign in children because of kind of inflamed lymphatic tissue. Usually when it's older adults, I do warn them, it could just be, you got some inflammation in there and that's what the appendix is. But in older adults, you worry a little bit more that it could possibly be cancer. So always double checking that pathology and warning patients like, hey, could most likely benign, but we'll talk about it. If you get a call from me, then there's probably a problem. But if you don't,
we're good.
We're good.
Okay.
Yeah. And I still discuss all the results and give people their pathology to kind of file away, probably in the garbage, but.
That's okay. I can't say I keep all my medical records and documents that like your next post-op appointment.
Exactly.
No. Yep. I'll remember. Here.
So what ultimately causes somebody's appendix to rupture then?
So usually waiting too long.
And then it just...
Yeah. Once that lumen gets clogged off, then things start to die. So then basically your venous supply in that appendix doesn't work, your arterial supply doesn't work. And then when you basically have no more blood supply to a certain area, it gets necrotic or dying, and then it can pop with a little hole.
Sounds painful.
Yeah, very painful.
Sounds very painful. No, thank you.
Okay, let me look. Okay, let's talk about GLP-1s.
Okay.
Please, I've been so excited about this topic. I have so many questions for you.
Okay, perfect.
Okay, so what are some of the medications of GLP-1s like that are out there on the market?
So the most common one people hear about, probably from looking on the internet or all of our celebrities is Ozempic. Seeing Ozempic face, Ozempic butt, all of those things. Mounjaro is another really popular one. And then one that a lot of people are kind of learning about more is Zepbound. There's also Wegovy and Saxenda, which are a little bit older ones. They all basically kind of do the same thing.
Okay.
So, or you've also heard of the compounded ones. You just have semaglutide in them.
Okay.
So they all work by kind of increasing that GLP-1 hormone. And some of them work by increasing other hormones along with it to kind of help with kind of the hunger and stuff like that. Okay. But they all kind of basically work the same.
Okay.
Helps it basically paralyze your stomach, which that means you don't want to eat as much.
Yeah.
Yeah.
So when people say, oh my God, I heard it paralyzed my stomach. It's like, well, yeah, duh. That's what it does. That's why you don't want to eat as much because it doesn't push the food through as fast as, you naturally would. It also kind of tones down kind of like your hunger demons. So that little, demon on your shoulder being like, you're hungry for some chocolate, kind of slaps them down and you don't have that as much.
Yeah.
The biggest problem with them is when you stop using them, all that stuff comes back because it's not curing anything.
Yeah.
Right.
So it basically just kind of makes your stomach not work as well, keeps those hunger hormones kind of at bay, but it's only while you take the drug.
Okay. So I have a question on that note then. So I majored in biomedical sciences. So based on my understanding of like people that are like type 1 diabetics where they're producing too much insulin and then like the receptors shut off. So if somebody's on a GLP-1 supplement or shot or whatever for too long, can that happen where they're affecting their receptors and then they need to stay on it for a while? Or
you don't know.
That's what I'm curious about.
And so any of the none of the long-term data has, when I say long-term, we've had these drugs for a few years.
Yeah.
So we don't have studies that are going, 20 years out, 30, 50 years out. And so it's kind of like use it to your own discretion.
Yeah.
And so will it, cause, more pancreas issues in the future? I don't know.
Yeah.
More, we like to say more than likely and hopefully not that we're not going to all of a sudden see a huge, increase in pancreatic cancers or things like that. We hope not. Right.
Right.
But we just can't know for sure.
Yeah.
Same thing with any of these GLP-1 medications, anything that causes you to lose weight with these surgeries. I mean, patients have surgery. I recommend not getting pregnant for a year. And I also warn them you're going to be your most fertile as well. Because I don't think that patients are getting the adequate nutritional guidance, looking at their actual weight. Are they losing it healthfully or not?
Yeah.
As well as guidance as far as like, you are going to be the most fertile you have ever been, period, whether you have surgery or on a GLP-1 medication.
Wow.
And with that, if you get pregnant on a GLP-1, we do not know what it does to the fetus.
Oh, wow.
The recommendation right now is to stop.
Mm-hmm.
You know, so if you do get pregnant and you are on a GLP-1, like, we don't know what happens. And so we again, people need a little bit more education and guidance. And I think that the best place for that is going to be with the appropriate person.
Yeah.
Not just getting it from an online source where there's really no follow-up, or an online, you know, telehealth, whatever, where the person really isn't invested or cares about your outcome and what your goals are. So.
Wow, I never knew that.
Yeah, me neither.
Just tells you right there.
Yeah.
So when patients come in, you kind of walk them through all of their options.
All of the options.
Okay.
Yeah. And some people aren't ready to commit to surgery.
Yeah.
They want to try the medications first.
Mm-hmm.
And so we try to really work with people to try to find a way, like, you know, hey, do you have sleep apnea?
Mm-hmm.
Awesome. Because Zepbound just got approved to treat sleep apnea, which is great.
Okay.
You know, surgery can reduce, you know, and cure sleep apnea like 90% of the time. But these medications, also because you're losing weight, help to kind of decrease either your use of your CPAP or maybe hopefully get rid of sleep apnea.
Yeah. Right.
But we try to, you know, work with insurance companies. A lot of them are still getting denied because if you're not really a diabetic or a sleep apnea, it's really hard to get you approved for these and not pay $1,500 a month.
Right.
And these are lifelong, which I don't think a lot of people either get that information, that this is lifelong shot. You can never come off of it. You know, the chance of you regaining your weight is really, really, really high.
Okay.
Some people think I can just change my lifestyle and this and that, but that hunger hormone, when he comes back, he comes on strong.
Right.
So
sure.
like people can have really good willpower, but that's a lot for anyone.
Cost wise, if you offset shot versus surgery, what does that look like?
So you have to really think about what is best for you.
Mm-hmm.
So is surgery, if you're paying cash, expensive? Yeah.
Mm-hmm.
You know, around the country, most places, you know, a sleeve gastrectomy, you know, all in with all of the things. If you're careful, you'll get the fine print on those at certain places and what they actually include. Can be about $9,000 to $14,000.
Mm-hmm.
That's like, oh my God, that's like, you know, a vehicle, right? That's a lot.
Right.
That's a one-time cost.
Mm-hmm. Right.
Whereas if you want to add up, even if you're getting a GLP-1 shot, $400 a month, which is very discounted, it's $400 forever.
Yeah.
And then at 67 weeks, the shots now become ineffective at any weight loss. You have to keep taking them to maintain.
At what point do you really cap out? Like, do you see like a month marker?
67 months.
67 months. Okay. And then that's when you transition to a different medication?
Nope.
Or
you can't. It's
not
their body's
effective
sensitized.
anymore.
It's not effective. You have to be on it to maintain.
Okay.
But they are great medications to help get people also ready for surgery.
Yeah.
So if your BMI is too high and you're not safe for surgery, it helps you kind of get down. Also, if you respond to medication, we know you're going to be a really high responder to surgery. Push this sleeve.
Really? Okay.
And then it does really help to augment, you know, after surgery. If you start a GLP-1, like 3 months after surgery, people will get an additional 10 to 15% more of their weight loss with it.
Wow.
So there's still great medications.
Mm-hmm.
I'm not going to sit here and say they're bad or always surgery. Everyone's choice is different.
Yeah.
Right.
And so if, you know, people want to have like, you know, 20, 30, 50 pounds off, man, I wouldn't recommend surgery. Because my mom is on a semaglutide.
Mm-hmm.
Yeah.
Because surgery is just not the right choice for her.
Mm-hmm.
Right.
So and she's done well on it. She's maintaining herself, and she's been on one for, you know, 2.5 years, and her knees no longer hurt. Her back no longer hurts. Because she was able to get that, you know, 50 pounds off that she never could get off with just diet and exercise alone.
So is she now like on a maintenance style?
She is.
Okay.
Yep.
Okay.
Yep.
So what do you do with your patients to help? So my understanding is that some people lose muscle mass at times.
They all do.
So how do you help your patients not lose muscle mass, I guess?
That a huge part of that is the follow-up.
Okay.
So people lose a ton of that muscle mass because they
Yeah.
are getting prescribed these things by people who are not educating them on the front end.
Yeah.
Right.
So they're getting these shots and they haven't changed anything about their diet.
Mhm.
Or they're on a very caloric restrictive diet.
Mhm.
So yeah, they're losing weight, but they're not losing it healthfully.
Right.
Yeah.
And so you end up losing it in your thighs, in your back, which is super important. There's multiple studies that are out now that literally correlate directly your lean muscle mass in your thighs to your longevity.
Wow.
Which makes sense, right?
Yeah.
Think
Right.
about, you know, one of the tests we do for elderly on how functional they are. Can they go from sitting to standing well? That's all thighs.
Yeah.
Right? That's all thighs.
Yeah.
And so we want to monitor people on these medications, you know, increasing your protein amount, just like the surgeries, 60 to 90 grams a day.
Right.
And then that scale, again, for our patients here, super helpful to look to see where they're at. I mean, I had a patient the other day and she was so great. She could care less what the weight said. She's like, I don't know what my muscle mass is. And I was like, girl, you got it. Like, it went up like a couple pounds. And she's like, I'm so worried about that. I kept thinking about that. And I was like, yes, the message is getting through. Like, this woman is kicking butt.
Yeah.
And she is most concerned about her muscle mass.
That's awesome.
And she was telling me about, I've increased like my activity. I'm doing these little like arm weights. Like, she was so jazzed. And I was like so proud of her. Like, that's again, proud moments where I'm just like, yes. I love you.
Proud mom.
Yes, I am. For sure.
That's awesome. What causes that from taking the shots? Just people not eating and then they don't have that fuel?
Correct. Yep. The same thing would happen with surgery, but because bariatric surgery, just for insurance requirements, requires nutrition visits, requires all this pre-op kind of education.
Yeah.
People are a little bit more aware and at least be on board for the year, right?
Right.
But these shots are given out, there's no education, there's no follow-up, and so that's where you're seeing people lose a ton of that muscle. And also there's no education. Like, hey, at 3 months post-op, I am hammering people like, get into the gym, do resistance training. I don't care what it is. Like, get some resistance bands, because if you don't use it, you will lose it. And your body is stupid.
Yeah.
Like, you can't text it and say, hey, just take the fat. It is dumb. It will take whatever source it thinks is easy. And a lot of times it's muscle.
Yeah.
So it's not like anything inherent to, a semaglutide to go after your fat. It's just people aren't educated enough to
be fueling.
I mean, my mom wasn't, to be honest with you. I looked at her and she looked terrible. And I was like, oh my God, you look like Skeletor. Like, her face was sunken in. Her body looked, she had lost weight, but it just didn't look healthy.
Right.
And I asked her, I was like, I'm so embarrassed, but like, I was like, Mom, like, how much protein have you had? And she's like, I don't know. And I was like, wrong answer. Like, I was like, okay, we're going to the store. I was like, what do you like? Chocolate or strawberry?
We're meal prepping. We're hitting you on a diet.
So, I mean, luckily, like, I grew up with, very health conscious parents that are, eating things. So thank God she loves cottage cheese, which is so hard to get people to like that stuff. But it's so good.
It's so good.
It's so good.
Yeah. I've never really had it because it just kind of
I think we talked about this like 2 weeks ago.
Yeah, we did.
Oh, it's perfect. It's like the best food ever.
What do you mix with that?
Man, whatever I feel like. I just eat it just straight. Honey, berries. I'll go savory. I'll put like some olives and olive oil.
I've never tried that.
Oh, it's good. And like some like bell peppers. Oh yeah. And some like salt and pepper.
Okay, Sarah, we can try it this weekend. You can make me try cottage cheese.
Yeah, you can make it whatever. It's like, it's so adaptable, and they have so many good recipes. Like, grind it up, and make ice cream out of it, or like pizza dough. Like, some people are very creative.
Do you have any sort of, speaking of, like, do you have any sort of what are they called when you're cooking? A cookbook. Good Lord,
I don't. When we basically give patients kind of like a pamphlet, as kind of like book to kind of go through like the different stages of their diets. I try everything, and so we kind of give them options as far as their protein drinks and stuff. And then I usually ask people kind of like what they like. If someone has a sweet tooth, I'm like, okay, I got you covered. Like, here are some recipes that I've 100% personally tried that are good, whether you're, a chocolate fan, vanilla fan, whatever, that won't be like loaded with protein, low carbohydrate, or maybe they're a savory person. To just try it. And I don't have a whole big, elaborate, thing of it, but it's helpful to have a staff where we've had multiple people in our office that had bariatric surgery and on their journey, their own, have found stuff. So we try to make that a community. Plus, we have support groups where people can share that as well.
No, that's awesome.
So,
good. That's amazing.
The internet is amazing. There are definitely cookbooks on Amazon, like packages for bariatric surgery that people can buy. So
very cool. It's interesting. I love that. Yeah, I'm such a bland eater. I was wondering how you help your patients stay creative, but that's because I have to.
Because you meal prep just. No offense, but boring.
So I never put any thought into it. I'm like, chicken and rice. I've switched it up lately with some beef and sweet potatoes.
Yeah.
And then I obviously eat greens.
Yeah.
That's about it.
Yeah.
So, and protein shake.
Yeah, exactly.
So there you go. Okay. So as a female surgeon in a male dominated field, what challenges have you faced and how have you overcome them?
Ooh, that is a loaded question. So I will definitely say when I was in training,
Okay.
and this is something I think most females have had said to them is, are you sure? Do you want a family ever? Because if you do, you should not do surgery. People are usually not very supportive of a female going into surgery. I think it is getting better, but I don't want to age myself because I'm obviously very young. But this, 10 years ago or so, like that's how it was. Yeah. When I was applying to residency programs, part of my choice looking at it was looking at their current residents. And if it was all male, there was definitely many programs out there at that time. This is only 10 years ago. All male, one female, all male, classes that just had, no females at all. Wow. And so I would choose ones that were heavy female. That meant like taking one female a year.
Yeah.
And they always, they're not supposed to ask these things, but, are you planning on having a family? Like, cause they're so worried about you getting pregnant. Because obviously that puts the workload on the other residents. You have to take, the lots of time off, which is like 4 weeks. Yeah. Is all they'll give you in residency.
Wow.
Yeah. And it's obviously with a lot of kind of like, turn noses. But even like when you're there, like if you at all are feeling sick, just the comments of like, are you pregnant? It's like, really? Oh yeah. It's like, just because I'm a female and I don't feel well today doesn't mean I'm automatically pregnant. Like, or comments where, they're like, okay, honey, okay, sweetie. And you're like, do you call the males that? Yeah. So I remember operating with this guy who's not well liked. And he was very condescending. He'd always call me honey and sweetie. And so I think it was the first time operating with him. And I looked at him and I go, okay, baby cakes. And he just stopped. And he's like, what? And I was like, well, I thought we were giving each other pet names.
I love that.
And he was like,
oh my gosh.
I'm sorry. He goes, I will address you now as doctor. And my main name is Holly. Yeah. And I was like, I appreciate that. Thank you very much.
Thank you.
I've never tried to like, turn on my light. Like I rolled in there with my Hello Kitty scrub cap, my Hello Kitty pink, like badge. Like I dressed up, to clinic and dress and heels. Like I wasn't going to, act like a guy because I was in a guy field. Yeah. But it's still, it'll get to you, like, or operating. I have probably the smallest glove size hands. They're a size 5.5. Most people have no idea what that means. So basically very small hands. Most men, for just comparison, most all laparoscopic instruments are made for a size 7.5. So for staplers, like I can't one hand them because I physically can't. A lot of the laparoscopic equipment, it hurts because it's not made for my size hands. And I have to, do certain things like prop up with my hip or whatever. But so that was a lot of times where surgeons would think that you're not as capable as a male because you're struggling or you're clumsy with an instrument, that they think that equates to not being good.
Right.
And so again, like, in cases where their hands were too big to fit somewhere and my little devils could get in there lickety split, like I would again like highlight them like, okay, see, it is nice to have dainty female hands where I can get into small areas where your big old clumsy hands cannot. Yeah. So, there's different things now that as things have changed and, surgery is a constant evolving field, but one that kind of big levelers of the playing field, especially in minimally invasive surgery, is the use of robotics because everyone's hand is the exact same size in that console. Yeah. And so that will also save my hands. I've already had steroid injections in my wrists because of laparoscopic surgery.
You have already?
Yeah.
Wow.
A lot of
women. At
what
point did you start having to do that?
I did that in residency.
Wow.
Yeah,
really?
My 5th year. Yep. I actually, my last kind of thing I did for residency, you had to kind of give like a grand rounds presentation, and mine was on surgical ergonomics. And, women are far more affected with ergonomics than men because the rooms are set up for someone who's taller, bigger hands. And so we tend to suffer, especially shoulder, elbow, wrist strain much more than a male. And so hopefully we'll see kind of a decrease in that, as things get more ergonomic for everyone and more females are going into medicine, they're going into surgery. Because thank God the American Board of Surgery at least approved and lengthened without it was almost punitive to have a baby in residency. You're basically going to add an extra year onto your residency. Wow. And now they're allowing people to take, 12 weeks off without having to skip a year or add on a year. And so it's become much more female friendly over the last just few years.
Okay.
And so now I'm seeing more and more classes of surgical residents that are all female.
Oh, wow. That's awesome.
That's amazing.
Which is mind blowing.
Yeah.
And I was 10 years ago picking a class because they had one female.
Mm-hmm.
And I thought that was huge.
Look at you paving the way.
So, I mean, it's a hard road. And like, I definitely, in fellowship, I love him to death, but hate him a lot at the same time. Mm-hmm. It's like, he was very hard on me. He was much harder on me than my male counterpart. Mm-hmm. And just from hearing that he's always just much harder on the females.
Yeah.
And I don't think there's anything wrong with him. And I don't think he even knows. Mm-hmm. I think it's just that subconscious bias of like, you know, and then of course I did get pregnant in fellowship. So he hated that. He didn't say it directly, but I don't think he loved that.
But look at your beautiful munchkin.
But she's perfect. I'm sure she heard lots of yelling in utero. Every time I tell her, I'm like, it's okay. He's just having a bad day. But I still love you. Don't listen to that. So,
well, I can't blame women for that though, because you're in school for so long. It's like, at what point do you pull the trigger and start your family?
Absolutely. Infertility is excessively high in women surgeons. Excessively high.
Really?
Wow.
Oh, it's terrible. Because we wait for so long and the stress of our job. Like miscarriage rates are excessively high. Just not being able to get pregnant at all is excessively high. Mm. Like, I mean, luckily we had no problems because I am just come from very fertile stock apparently. But most women surgeons struggle significantly. And and then again, like when you're in residency, they don't really pay you for, you know, we make basically less than minimum wage with the hours we work that most women can't afford to, you know, freeze their eggs or save their eggs if they haven't met the right partner or anything like that. So it's hard.
Yeah.
Wow.
So.
Wow. That's crazy. Sarah, have you ever gotten asked the very first question she said that, are you sure you want to do this? Or do you want to have a family? Because I've gotten asked that question too, just coming into this industry.
I have not.
Mm-mm. People have asked me before. I think it was like other male reps so I was talking to, but they're like, well, do you want a family one day? And I'm like, yeah.
I think really for me, it was, I mean, I didn't get into this industry till after I was married and had a little
That's
one.
true.
So it was like, it was more of, this is my why. I want to make them proud. I want to do something that's impactful. And this is why I want to do this. And so I don't think there was any way around that question.
That's true.
Me. Yeah. But I can see how that's
that.
very challenging though
Yeah.
Wow.
It's getting better. Like every day, every year it gets better. And then, you know, unfortunately, I think the women are harder on other women. I mean, a lot of women are pretty hard because a lot of the women surgeons that came before me, man, they had a really rough road. Yeah. Like they had to really, you know, be very masculine and had to really, they went through the trenches, man. What I went through is nothing compared to what, you know, someone who's, you know, in their 50s or, you know, early 60s, like the roads that they had to go through. Right. Respect. But it really hardened them.
Yeah.
A lot of them are very hardened from those experiences because it was pretty bad. So
I've noticed that. Yeah.
Wow. So I would say the other thing was, when I'm speaking of nurses, I've noted that was probably the most annoying when I was like a resident was like, I was with another male resident, same level. We're both interns. You know, the nurses would like, granted he was single and a doctor. The nurses would jump over themselves, push each other out of the way to get stuff for him. They're like, oh my God, Dr. blah, blah, blah. Let me get this for you. And I'm like, hey, can I? And they're like, bye. See ya, chick. They would not address me by my last name. They wouldn't say doctor. They would call me Ashley.
That's so rude.
Yeah. Or I loved it rounding with like a male medical student. And so our codes are different lengths based of, you know, kind of our level we're at. So when you're a medical student, you have like this short little white coat and you're stuck with a bunch of things that flails out. Like they're terrible. And then like the awesome part, when you graduate, you know, you get this long lab coat. You're waiting for the long one that goes to the knees.
Yeah.
And so I'm, you know, rounding and with a patient and I introduced myself. I'm Dr. Holly, blah, blah, blah. My little male medical student who's like, like in the background, like has no idea what's even happening. He probably wants to do psych or something. Yeah. And the patient just looks right at them like the whole time and like talking to him. And I'm like, he knows nothing. He is barely here. I was like, he barely found the like lounge today. I was like, so we're going to come back here. You're going to tell me about your abdominal pain because he doesn't even know how to find your abdomen at this point. So
He'll get there, but not today.
But
Oh my God, that's
funny.
hilarious.
Oh my gosh. Okay, so what are some of the challenges and amazing rewards of establishing a new practice in a smaller market?
Ooh, I mean, just establishing a new practice, whether it's a smaller market or a larger market, I think it'd probably be harder in a larger market because you're essentially like, a little fish in a huge ocean to kind of set yourself apart from other people kind of doing the same thing.
Right.
So anytime you start something new, which is not new to me. I helped start a new residency program. I always feel like I'm on like the forefront of starting something new. There's going to be growing pains. And so, we just try to have people just be patient with our process. Like we'll get there. It may not be the most perfect road initially, but we will figure it out. The thing is just having the commitment to do it.
Yeah.
When you have a whole team really committed to the process, it's like, we may have some hiccups, we may have some speed bumps, but as long as we don't just let those little hiccups and little speed bumps derail us from like the main mission, that's really the big thing. So a lot of it's just kind of, again, communicating with patients, communicating with staff, to make sure that everyone's kind of aware, like, hey, this may not be perfect, but we'll get there.
Yeah.
And just have some grace with this process with us. Do I get frustrated because I came from a very well-oiled machine? Absolutely. But this is not the same thing at all. Like we're starting something, in my opinion, that will be better for the patients, better for everybody.
Absolutely.
So
yeah, that's amazing. That's awesome.
But this community, in a smaller community, I think it's easier.
Okay.
It's much easier I came from a small community. And so it's much easier to have connections made.
Right.
Everyone knows everybody. And so when people have really positive outcomes with you, that ripple effect is felt far more in a smaller community.
For sure.
Obviously the pressure is also there. Like if you do something bad or you're not, putting the right face forward or not treating people well, that ripple effect is also felt. And that can be really hard to recover from.
Right.
So just kind of knowing where you're at. I mean, it helps that I grew up in that. So I know very much, you want to always have a good positive attitude and treat people like family. If you treat people like family, you will never go wrong.
Absolutely. That's what I love about Abilene. I love about, we talked about this on our previous episodes, but I just will never leave. I love this community and the people here and the patients here. I mean,
they're the best.
Everybody's so loyal and just kind, and it's just a wonderful community.
Yeah, they're not entitled. They're like, I've never met so many people that were so appreciative of just basics.
Wow.
And that's just, it makes it really rewarding to even be on call. Like, can call be annoying to most general surgeons hate being on call. But it's rewarding. Like you make connections with people and their families, and maybe able to like hug a mom and let her know that her kid's going to be okay and help have her that relief. And she's like, I was really scared before surgery, but you made it better. Like, that is so rewarding because it is scary. Like I do this every day, so I'm not scared, right?
Yeah, right.
But you have to recognize like this is not an everyday for everybody. Like this surgery is a huge deal, whether it's just an appendix or just a gallbladder. Like might be like my 5th one of the day, but it's their only one, right? So
no, I agree. I've never had surgery, and I'm terrified.
Absolutely, it's surgery.
I've never even been under anesthesia. I literally have no idea what it's like, and I don't want to find out.
I'm always curious, like when I'm in surgery, I'm like, I wonder what my insides would look like. I wonder how, I'm so curious. I'm like, I'll be the next patient.
I don't want to know anything.
Really?
Oh my God, no. I don't want to know anything. Like if I granted I had a very horrible birthing experience, so I got put out completely. But like even then I always joked, like if I ever had to have a C-section, they should just put me out completely because I don't want to Monday morning quarterback, like, how are you sewing me up down there? Or like feeling the tugging and pulling. Like I would probably just pass out because I'm a chicken. I can't see my own blood. I like don't like it.
Really?
Oh my God, no. I can be elbow deep in somebody, but my own blood, nope.
See, that's so interesting too, because like I can stand in surgery all day and watch, but like if I go get my blood drawn and stuff, no, my mom's had to sit there and hold me before because I'm literally pale in the face and about to pass out. And the nurse is like, oh my God, I'm making you some crackers or something. And I'm like, Mom, she's like, stop looking at it.
You can't look at it. You can't look at it. You can't look at it.
It's like anything like needles and stuff. It just, it bothers me.
Yeah.
But I can watch surgery.
Like,
so weird.
I can perform it.
Yeah. Not weird.
Yeah.
That I one time I did see it was a student, poor thing. She came in and she was a nursing student. And it was, her clinicals, she went down.
Oh.
Like she went down. I was like, oh, poor thing. I mean, because you just don't know. You know?
don't.
I mean, like psych clinicals in nursing school, that would have been a no-go for me. You know, like that's part of the reason why I changed my major. I was like, But yeah, it's so crazy. Like, and some people don't know until they're immersed in it. And then they're like,
there was always certain procedures we knew that higher chance of med students going down.
Really?
Oh yeah.
What were what are those?
So
that's funny.
People tend to have a really hard time watching like preparation for like skin grafting.
Okay.
Because you're skinning a human being. And I think that like when you think really about it, it's like, so I've seen med students go down with like, it's called a dermaplaner. It like basically skins you.
Wow.
That's what it does. Or when we are doing a breast lift, because again, you're like, we call it de-epithelialization of the breast, which is basically skinning the breast. So you have to get the breast tissue ready to like be able to make the incisions correctly. And with the de-epithelialization of a breast, because you're seeing much more of the person and knowing it is a person. It's not just a little square, you know, whatever. That, oh my God, they would go down, down, down.
Oh
like we would just not even let them come to like close to the table because we had so many go down.
Oh my God.
You don't want them to break the sterile field.
No, especially because with plastic surgeons, man, they are particular, and it would take, I think it took 20 or 30 minutes just to drape the person. And so if they would have like, it'd have been bad. Bad.
Oh,
but
that's crazy.
Any sort of skin removal, people have a really hard time with.
I think I would too. I don't know.
I've never seen it, so I can't say. I know I've done thus far. I'm a champ with most things and can handle and see it. Throw up for me though is a no-go. It's a non-negotiable. Unless you want to be thrown up on too. Like, I mean, it's just, that's my only.
I love that.
That's funny. Okay. So how do you approach building trust and rapport with a new community?
So I think just going out there and doing good work. So I think that is a huge part, you know, again, like, you know, calling patients and families, making sure that they're doing okay after surgery. And again, just treating people like family.
Yeah.
If I wouldn't want that to happen to my mother or my father or my sister, then I wouldn't do it or recommend it, you know, and just recognizing that surgery is scary. So I think that's a huge part. I think also getting to know sort of, you know, the gatekeepers of the community. Those are your primary care doctors that are really on their front line, seeing lots of different people, whether they're the doctors, the nurse practitioners, or the PAs that are kind of seeing those patients. I think establishing a rapport with those people and kind of letting them know, hey, you're here. This is what I can do. This is what I can offer for your patients. And then when your patients have good experience with you, they're going to send more of their patients that way. Being like, hey, like, you know, she really took great care of, you know, so-and-so, like, let's continue to send people that way. So I think, you know, it's hard to kind of break some referral trends, especially when there's really great people in this community. Let's face it. There's really great surgeons that have really great reputations, and, you know, I'd let it operate on me, honestly. And so kind of breaking into that community and that referral trend can be hard, but, you know, just showing up every day and doing good work and treating people like I want to be treated. I think that's the best you can do.
Yeah, absolutely. I love that.
Awesome. Keep at it.
Yes.
Trying.
That's awesome.
Every day.
What advice would you give to women aspiring to be surgeons or in male-dominated fields?
I think do not let anyone dim your light. Be you.
100%.
And so, because if you start trying to make yourself like somebody else, whether it's choosing different shoes or that you're not going to wear that pink scrub cap or whatever it is, like, don't let anyone change what you want to do. Like, I wanted to be a surgeon since I was like little. Like, I may not be the smartest person in the room, but I am usually the most stubborn. And I attribute that to why I've never given up, because there's multiple points where I could have turned tail, done something different. And so you just have to, if you really want something, you have to be you. You have to go out about you, because if you enter this and you're not yourself, you won't be happy.
Yeah.
It won't be a good experience or journey for you. Like, it's a hard road. It's a long road, but really, really embrace the journey, especially for people who want to do in the medical field, whether you want to be a doctor and a surgeon, or you just want to be a doctor, you want to go to PA school, like, embrace the journey, whether that's stuck in the library studying your, you know, biochemistry or organic chemistry, like, enjoy the journey and you'll get there. And just don't let anyone talk you out of what you want to do.
Yeah.
If they are trying to, just think that they're just jealous or that they're trying to bring you down to their level. Because if anyone is saying that, they aren't really on your team, they're not supporting you. You want someone who's going to be your cheerleader and lift you up, because that's what I want to do, right? And the people that impact you, remember, you remember the most, like that were most impactful in your life, they were your cheerleaders, right?
Absolutely.
Sometimes those negative naysayers are also motivating.
Yes, they are.
That's true. We were literally talking about this earlier.
Yeah. I mean, I have a handful of those. And but, like the people that, that supported me or believed in me, like those who I remember the most. So really believe in yourself and then just hang on to those people that really believe in your dream with you.
What are your goals for the future, both professionally and personally?
Ooh, that's good. So personally, I mean, that's really easy to talk about. I had a baby 7 months ago, so I'm still trying to like learn this postpartum body and just get back to feeling like myself. So a lot of that is just being able to be in the gym, most every single day, being healthy, like weight, whatever I don't really care about. I am very obsessed with trying to live a very healthy life. So I'm sure RFK would love to hear this, but eating healthy, like, I have my little organic garden, trying to protect it from the deer. That's goal number one. But just kind of getting more immersed in this community that I'm, we're making our home. That's like the goal over the next year is really just learning more about the community, being more immersed in it, getting involved in the community events and stuff like that. That's really a big goal. Also just kind of really establishing kind of like a good work-life balance. That's always hard. But learning that in this, new role, no longer being in training, and having a kid, which is also very bizarre, but, kind of establishing that.
Yeah.
Professionally, goal number 1, 100% without even blinking is to work on getting this hospital system an accredited center for bariatrics. That opens the floodgates to helping so many more people. And so that's really the main goal. Like obviously providing great care to the patients that I have and continuing to support people through their process. But I want to be able to touch so many more lives. Granted, when I do have to refer out, I refer out to people that I personally know and trust. But obviously I always think that I want to keep people here. Absolutely. Just because their families are here, their communities here, whether that's like their church community or just like they have a really big family, whatever it is. Yeah. And so getting an established kind of accredited center in this region, which would be a game changer for so many people because people don't want to leave here. They are like forced to because of insurance. Yeah. And so that is number 1.
What does that do? Like accredited versus non-accredited?
So, I mean, it doesn't mean there's anything wrong with the hospital system. Right. So that's like a big misnomer. People like not accredited. Does that mean it's not like a good hospital system or whatever? Right. It has nothing to do with that. It has nothing to do with the surgeon. It's literally just a numbers game. And that is literally all it is. You have to have a certain number of cases performed at a certain hospital. Okay. And then you can kind of ask for the blessing from like the American College of Surgeons. They kind of grant that kind of accreditation. And then once that happens, then insurance companies, again, this is all insurance company based. Then once that happens, then the insurance company's like, okay, like then we'll allow you to take our patients. That's all it is.
Gotcha.
So they just want somewhere that's done a number of cases and it's reflecting, nursing staff has their education, the emergency department has their education, just that the system's going to work for this special population of people. So.
Okay. Wow. And then any upcoming projects or initiatives that you are excited about?
I mean, I'm always excited about more surgeries, honestly. Like getting people through our kind of network and our pipeline with the hospital I work at. The employees have amazing benefits for their bariatrics. And so this happened in February. So people kind of popping through and we're going to start getting their surgeries done. So I'm very excited for the people that I know are kind of the upcoming surgery. I'm like so pumped for them. Of course, there's, other community events that are going to be upcoming in April as well as May. We kind of just talk more about just different technologies as well as just, bariatric surgery or just even like the whole service line with medical weight loss and everything that, our clinic offers. So
that's really good. It's exciting.
Are there any like networking like groups here in Abilene that like you can utilize to just help grow your network and connect with other people?
That's a good question.
Because there are like, I know like in Rockwell where I grew up, there's like little networking groups where everybody who like owns a business, or I think there's some for like the doctors there, they all like get together and then but maybe you could think about starting one if there's not one here.
I mean, they have different ones here. So they have usually there's some sort of medical society. The medical society here in like kind of the big country is actually really active. And so I am part of that. Okay. And then, any sort of chamber of commerce event, those, talking about your business owners, new business owners and stuff like that. just to we had an event recently that involved kind of the Chamber of Commerce. And so, we were approached by different people in that, event to kind of speak at their organizations. And so that's a great question. I think there are some, again, like I'm new to the community, so I really lean very heavily on people who've been in this community much longer, that are much smarter than I am, that just know those resources better.
Well, that is awesome to hear. We have really enjoyed getting to know more about you and your practice today, learning about GLP-1s and the different, I loved your props that you brought, all the different procedures.
These are like my favorite little guys.
They match too. I love it.
So I am very visual. So if you ever come to the office, like those boards I brought up earlier, I can draw on them. And so whether it's someone's gallbladder or whatever, like I am very visual. So when I saw these little stuffed animals, essentially, I was like, oh my God, I need these. So we don't have one for a Sadie. So I usually will just like separate these two. I'm like, okay, in a very magical land where a bypass, which is this guy, and a sleeve have a baby, its name is Sadie.
Oh, that's cute.
So it's fun to have patients see. It's like, where I can take stuff out. It's like, okay, this part stays in your body forever, and here's this guy. So it's helpful for people to see kind of what we're doing to them.
I love this.
Is everything perfect? No, but it's also really cute to have pink toys.
Oh yeah,
so I like anything that's very girly and stuff like that. So I'm like, they're so cute.
Oh my gosh, this is 80% of your stomach that goes
80 to 85. Everyone's stomach is a little bit different, but then I can like put him on the trash can in the office and be like, he goes by. So
that's awesome. I love it.
And if anyone brings like little kids in, a lot of times these are really great to distract. Like, here, why don't you take the sleeve?
That's awesome.
Those are awesome.
Well, thank you so much for joining us. We really appreciate it and learned so much today from you. And we're both super excited to watch your practice here at 100 kick off in Abilene. And
absolutely,
it's going to be great. Absolutely. So super excited for you in your future.
Well, thank you very much. Thanks for having me. I love talking to you guys.
Yes, absolutely. Thanks. Okay, and stay tuned for our next episode. Bye, guys.